Good afternoon. My name is Hyeok. I'm an associate professor of the Chung-Ang University College of Medicine. I will introduce the association between acute kidney injury and outcomes after an out-of-hospital cardiac arrest based on the data of the Korean Hypothermia Network Prospective Registry. First, I will introduce the definition of AKI. AKI means acute kidney injury. Second, I will introduce the association between AKI and outcomes after out-of-hospital cardiac arrest. Third, I will introduce the effect of RRT. RRT means renal replacement therapy on the outcomes of AKI after out-of-hospital cardiac arrest. The most commonly used definition for AKI is proposed by the KDIGO. The KDIGO published the Clinical Practice Guideline for AKI in 2012. Everybody can access the guideline on this website for free. AKI is defined when one of the following conditions will be satisfied. First, increase of serum creatinine above 0.3 mg per deciliter within 48 hours. Second, increase of serum creatinine over 1.5 times baseline within 7 days. Third, decrease of hourly urine output below 0.5 ml per kg for 6 hours. Once AKI has been defined, then we should classify the AKI. The staging of AKI is classified from stage 1 to stage 3. The severity of AKI increases from stage 1 to stage 3. The advantage of the KDIGO system is considering both the serum creatinine and urine output. In addition, an increase in serum creatinine over 4.0 mg per deciliter or initiation of RRT is regarded as stage 3 AKI. If you check the papers on the AKI, some authors regarded first value of serum creatinine measured within 3 months as a baseline value, and others used the first measured value of serum creatinine as a baseline value. However, these methods were incorrect. The KDIGO guideline recommended that the baseline serum creatinine value by using the equation from the modification of diet in renal disease study. By using the equation from the MD-RD study, we can easily estimate the baseline creatinine value. I will introduce the dataset from KORHN Prospective Registry. KORHN is an abbreviation of the Korean Hypothermia Network. KORHN is a multi-center clinical research consortium for TTM in South Korea, which is established in 2011 and covering 32 academic hospitals. Recently, KORHN had completed a prospective registry study on TTM. We call it KORHN-PRO. Out-of-hospital cardiac arrest patients who were treated with TTM had been enrolled between October 2015 to December 2018. In total, 22 academic hospitals participated in the study. The primary endpoint was survival status at 6 months since the return of spontaneous circulation. During the study period, 10,426 out-of-hospital cardiac arrest patients had been screened. After excluding several conditions such as no sustained return of spontaneous circulation, 1,373 out-of-hospital cardiac arrest patients who were treated with targeted temperature management had been enrolled. For analyzing the effect of acute kidney injury on outcomes, pre-arrest chronic kidney disease, end-stage renal disease, and the patient who died within 48 hours of return of spontaneous circulation had been excluded. In total, we analyzed 1,000 63 patients. The incidence of acute kidney injury in our cohort was 55.5%. Most acute kidney injuries had occurred within 3 days of return of spontaneous circulation. 19.5% of patients with acute kidney injury were treated with renal replacement therapy. In cases of stages of acute kidney injury, Stage 1 occupied 43.6%, Stage 2 occupied 18.6%, and Stage 3 occupied 37.8%. The primary outcome, that is 6-month survival rate, was significantly different between the patient without acute kidney injury and the patient with acute kidney injury. The ratio of good neurological outcome, that is cerebral performance category 1 or 2 at 6 months, also significantly different. Both outcomes were significantly higher in patients without acute kidney injury. Interestingly, outcomes were significantly decreased with increasing the stages of acute kidney injury. In contrast, the ratio of deaths at 6 months were increased significantly with increasing the stages of acute kidney injury. Survival analysis also showed that the cumulative survival was significantly higher in patients without acute kidney injury. Survival analysis according to the stages of acute kidney injury showed that the cumulative survivals were significantly low with increasing the stages of acute kidney injury. We also checked the effect of renal replacement therapy on the outcomes of acute kidney injury after out-of-hospital cardiac arrest. When comparing the mortality at 6 months between the patient who were treated with renal replacement therapy and the patient did not be treated with renal replacement therapy, the mortality was significantly higher in the RRT group. This result was reasonable because all of the patients who were treated with renal replacement therapy were classified as stage 3 acute kidney injury. The result was not changed when we restricted the study cohort with patients with acute kidney injury. However, when we restricted the study cohort with stage 3 acute kidney injury, the mortality of the RRT group was significantly lower than those of the non-RRT group. Survival analysis in the cohort of stage 3 acute kidney injury also showed that the cumulative survival of the RRT group was significantly higher than those of the non-RRT group. The hazard ratio of renal replacement therapy was 0.569. It means that renal replacement therapy might contribute to achieving survival gain in the cohort of stage 3 acute kidney injury. However, we could not conclude whether applying renal replacement therapy could increase the survival of the patient with acute kidney injury after out-of-hospital cardiac arrest or not, because our study was observational and there was no strict indications for renal replacement therapy in our trials. An additional randomized controlled trial with strict indications for renal replacement therapy should be needed to confirm the effect of renal replacement therapy on acute kidney injury after cardiac arrest. In summary, acute kidney injury was a potent predictor for mortality and poor neurological outcomes after out-of-hospital cardiac arrest. In addition, renal replacement therapy was independently associated with a lower risk of death in stage 3 acute kidney injury after out-of-hospital cardiac arrest. Thank you.